Great, thank you. And thank you all for joining us today. Like Ellen said, I'm Abigail Jones, a Vice President in our Medical Devices and Diagnostics team, and I'm joined by several of my colleagues with expertise across varying aspects of the healthcare industry. While we are a group of women who are passionate about helping our clients identify problems and craft solutions in today's healthcare market, we're also a group of women passionate about women's health, and we feel very strongly that we can do better to address women's needs. So we'll spend our time today discussing our observations and our thoughts regarding women's health and market research, as well as provide some insight into the ways in which Ipsos can support clients as they seek to improve the way that they think about women in healthcare. And now, before we get started, I do want to acknowledge that while we understand women's health from both a personal and professional lens, we cannot understand women's health from the perspective of women of color or other marginalized groups. So there are questions and problems that these groups face that go well beyond what we as a group of white women should be discussing today. So while we'll speak broadly about women as a category in healthcare, we acknowledge that women is not a homogenous group, and that should be taken into account when thinking about the unique and diverse needs of women. So now I would like for each of our panelists to introduce themselves and what it is that resonates with them about women's health. For me, I had a significant health event in the spring of 2020, which was, perfect timing with COVID, that got me thinking about what it means to seek care as a woman from female physicians and healthcare professionals, and kind of saw that in a completely new light. So I experienced firsthand what it meant to seek care for something serious. Unfortunately, I was the lead from the outset, and that worked well in my favor. I was able to get the care that I needed without too much of a challenge. But really, along my care journey and the countless hours that I spent Googling my condition, I started to really empathize with women who had the same condition as me, but drastically different experiences. And so now I'm really passionate about trying to help change that. I want us to think differently about how we view women's health and how we can improve outcomes and consistency of experience in healthcare for all women. So then, Stephanie, can you please introduce yourself?
Sure. I'm Stephanie Brown, and I have been leading qualitative market research assignments for 14 years now. And prior to that, worked in marketing roles in the health insurance and pharmaceutical industries. I relate to healthcare specifically through the lens of baby boomers, being one myself. And just to give you an idea of the size of this group, consider this statistic, which I feel is pretty stunning. In the year 2000, there were 35.1 million people who were Medicare eligible. By the year 2030, this is expected to almost double. So we're talking 69.7 million people who will age into being Medicare eligible. And of course, we tend to become more sick as we age. So consider the exploding demand for healthcare products and services, not to mention the impact on budgets. And of course, roughly half of these baby boomers are women. And it's entirely possible that they may have different attitudes about, different expectations for what it means to age in a healthy manner. They maybe have different ideas about when it's appropriate to intervene in a health condition, or what the appropriate out-of-pocket burden might be, or whether to engage in technology in the healthcare arena. They may have very different ideas than others. So just by the sheer numbers, I think women's perspectives and experiences shouldn't be ignored.
My name is Katie Phillips. I'm an engagement manager within the digital strategy team of Ipsos Healthcare's advisory branch. Women's health has been a topic that's always really interested and frustrated me. I was recently diagnosed with a condition that only women face. It was quite an upsetting time of my life and very frustrating, and I came across many male physicians who repeatedly told me I was normal, even though it felt like I was very different from normal. Across my time at Ipsos, both in the UK and in the US, I've focused on patient research, specifically bringing in the patient voice. And a lot of this was related to women's health projects. So I've got a lot of practice working on these projects and bringing forward the female voice to our clients, making sure that they understand the impact of being a woman and having various different diseases.
Hi, everyone. I'm Colleen Carpinella. I'm a director on the Ipsos quantitative healthcare team. And it's important for me to talk about women's healthcare today because I recently became a mom, and that experience allowed me to see firsthand some of the gaps that currently exist in maternal healthcare in the US. So, for example, I experienced firsthand a lack of consensus around workout and activity guidelines during the pregnancy period, and a general absence of available healthcare support during the postpartum period. So I'm working to ensure that other moms are equipped to better navigate their pregnancy and postpartum journeys.
Great. Hi, I'm Janet Creaser, and I'm the Senior Vice President of our Healthcare Human Factors and User Experience team here at Ipsos. This question is important to me because I'm a woman, obviously, and I've worked for over 20 years in R&D engineering. And despite the gains in engineering, most teams are still heavily male. And unfortunately, I have observed firsthand that implicit bias is real, and more specifically, that well-intentioned but heavily dominated male teams can unintentionally bring that bias to the design of processes and products. And in particular for medical devices, when we're talking about those that might be specific to women or have an equal number of male and female users, being able to account for the variability across all the users, but including the special needs of women. I don't want to say special, not a great word, but the needs of women is something that I want to help support as well.
Hi, my name is Ashley Lumpkin. I am the head of Ipsos's Health Insurance Advisory Practice. I come at this topic from both a personal and professional standpoint, as many of us do. Personally, I have a chronic condition that presents itself differently in men compared to women. I recently had a new provider ask me to prove that I had the condition before they would even schedule an appointment with me, which was a very frustrating process. Professionally, I'm really focused on access to care, and I think it's really important that our clients look at access to care through a gendered lens and really understanding the challenges and barriers that women focus getting the care that they need for themselves and their families.
Okay, so now we're going to take a minute and show a brief video that provides some research, an overview of research that was conducted by our quantitative custom healthcare team and the Ipsos Ethnography Center of Excellence over in the UK. So while this research really was conducted and is specific to the UK, I think a lot of the findings that were generated through this research are applicable to what we face here in the US and across the globe. And just a fun fact, our own Katie Phillips was involved with this research as well. So we're excited to share this video, and we're going to take a moment just to turn our cameras off to watch the video, and then we'll resume once the video is completed.
From the very beginnings of modern medicine in ancient Greece, the difference between the male body and the female body has been regarded in a sort of hierarchy, with the male being the superior norm, the standardized, stronger example of an idealized human. By the time we get to the 19th century, where we start to see our contemporary medical situation beginning to unfold, the image of the hysterical woman, which is a male-created medical diagnostic category to denigrate women, to make them at the whims of their bodies and irrational minds, really took hold.
And what we have in the 20th and 21st century is we blame it on women's raging hormones.
I've suffered from panic attacks my entire life. The first one that I remember was when I was 7. The doctors would say, oh, well, this will resolve when she gets her period. So somehow this was something to do with being a girl who wasn't menstruating yet, and that once I had my period, I would stop having panic attacks.
But these kinds of ideas about women being very difficult to understand, a mystifying puzzle, are so embedded in our medical thinking that we see them resonate when women are, for example, doubted when they try to explain their pain to a doctor or a healthcare professional, when we see women's accounts of their illnesses and diseases being distrusted, and when we see a general culture around women's pain and other illness symptoms being minimized, belittled and deprioritized?
It's just agony. Just absolute agony. I feel like I've been on an obstacle course, I guess. There was never a doctor who actually said, this is what it is. They just shoved me to another doctor. And that's how it was for it felt like years. So I got my medical notes. They said that they thought I had body dysmorphia. And then you have to tell your family and friends, they've told me there's nothing wrong with me. So then they think you're just a hypochondriac, lazy, complaining. I can remember one moment in the last year where I felt a normal person, and I remember just bursting into tears.
I've actually seen a doctor write down before, like when I've said, you know, like I was describing a particular headache or whatever, and they were like, so what would you rate that in terms of a 1 to 10? And I was like, at that time it was probably about an 8. And I've seen them write down 6.
It's been known for quite a few years now that black women in the UK suffer much higher rates of maternal mortality than women of other groups, and other ethnic minorities also face slightly heightened risks. And for a long time, this was just chalked up to this nebulous idea that they are different in some way. It's only been in the last couple of years that there has been some pushback to this idea that black women's bodies are different.
There's dismissal. One of the biggest examples of this for me recently has been the problem with mesh, vaginal mesh. It would cause erosion through bladder, through bowel, it eroded into the vagina. It caused people to have worse urinary symptoms. It caused things to get stuck together that shouldn't have been. And so women just weren't really, they weren't believed.
It's the same discourse which is actually positioning the problem within the woman, which allows us to position the woman as other, as outside. So we're actually seeing behaviours differently. We're seeing them through a gendered lens.
So now that we've watched that video, you know, as the video pointed out, women and women's health issues.
Sorry, I'm just going to interrupt, Abigail. I think you're sharing your screen still because we've got your notes up.
Oh, sorry.
And not your camera.
Okay. I pushed the wrong button. I'm sorry. Anyway, okay, well, since we watched that video now, I think, as the video pointed out, women and women's health issues have been othered in medical practice, and in medical solutions, we often see that companies and manufacturers gravitate towards this kind of one-size-fits-all approach. So my first question for our panelists is, why do we see that one-size-fits-all healthcare not really being a long-term solution for improving women's health and healthcare outcomes?
Yeah, Abigail, that's a great question, and maybe someone got a preview to the notes, but as we've heard during the introductions and from the video, a one-size healthcare solution is not likely to meet most people's needs. For women in particular, the historical evidence is very clear and highlights the biases against women in medicine that have led to difficulties in achieving positive health outcomes for women across the spectrum. You know, in addition to symptoms being overlooked as just part of being a woman, in many places we have laws and regulations that actually limit women's equal access to care. And we also have discrimination and sometimes in insurance policies, particularly here in the US, in allowing women to get access to specific types of women's care. It may be considered optional when it really should not be. And we have a really good example from 2016 study in Massachusetts that actually showed that the majority of health services women access for themselves are specifically for women's health needs, and that the one-size models are not really adapted to the life cycle of women. Overall, it's a little bit ironic, I think, because it tends to a one-size model tends to both over-prioritize as well as dismiss the symptoms as being female-related when they are due to disease, and often don't provide enough evidence-based attention to female-specific issues or to women when it is an illness that spans both genders or all genders, as we heard from Ashley in her experience.
I think also this came up in the hysterical health paper that was released in the UK. Speaking to different experts on this topic area, they found that quite a lot of emphasis was often put on biology, with not enough also put on social determinants of health. We all know we have unconscious biases. Doctors aren't prohibited from this, they also have them. So when we're not taking that into account in the care that Janet was saying in different areas, we're not taking into account the full picture here, and we're missing out on things, with pain, as discussed in the video, being something that is quite often underdetermined or diminished for women, especially women of color.
Furthermore, I would argue that the one-size-fits-all healthcare is really overlooking the fact that women are the most important healthcare consumers in the United States. So despite making up just over half of the population, women actually control 80% of healthcare decisions, which equates to $7 trillion in annual purchasing power. Women have a leading role as the chief medical officers in most of the family's healthcare. The majority of caregivers are women, and mothers are the primary decision makers for their children. So women need adequate knowledge and tools to satisfy their multiple roles as key decision makers and consumers of healthcare. Furthermore, I would add that women utilize more healthcare services than men. This is in part due to their need for reproductive services, but they also spend more money than men do on healthcare and often incur higher healthcare expenses than men in the same age group. So therefore, because of the important role that women are playing as key decision makers in the healthcare space and consumers and utilizers of the healthcare system, the system needs to be designed with women in mind.
Yeah, I totally agree. And I think that's something that we've really noticed, and I think a lot of attention needs to be placed on, is that we're not, when we talk about women's health, we're often not just talking about women as consumers of healthcare, but also as the providers of care, as physicians and as nurses, and also as caregivers for their children, for elders, for, you know, those around them. And so with that, just wondering now, what questions do we think that healthcare and med tech companies can ask themselves to better design and position their products and services for women and the loved ones they care for? Really thinking here, any types of questions or topics that you kind of wish clients would ask when it comes to improving healthcare outcomes for women.
I can take this one. I honestly think there are so many questions that we could be getting our clients to ask. I think the first one is thinking, like you say, about the differences that women have in their lived experiences in diseases, not just kind of these women's diseases like menopause or endometriosis, but how is it different for a woman when we're considering their patient journey? So we know that there are many conditions like autism, ADHD, and heart attacks, where the diagnosis rates are woefully low for women compared to men, because the signs and symptoms that they have are very different from the signs and symptoms that men have. And for however long, the norm has been educating about male conditions and the male signs and symptoms. And only now are we beginning to realize that actually the diagnosis rates probably are a lot higher than we think they are. So are we considering this when it comes to the patient journey, not just at diagnosis, but also at treatment? We know that some medications, some prescriptions are different for women than they are for men, whether it's the sizing of the script or how women are reacting to the medication. So are we kind of looking into these differences when we're creating the clinical trials, or when we're thinking about real world evidence that Ipsos can help with as well? And are we educating our female patients enough about what they should be expecting when they're taking this medication, what side effects could be for them in comparison to their male counterparts? And are we allowing them to have that kind of voice as well when we're thinking about what we're reporting back?
I want to jump in. I also think there's an issue of access to care, and, you know, for example, being able to find a provider in your local area, being able to afford the care that you need. I think this is highly gendered as well. And Colleen talked about women playing that chief medical officer role within their families, and as such, they're the ones who steer the access to care for their whole families. And so when there's a lack of access, women are the ones who need to find the workarounds, quick fixes, alternatives, which is really an evidence of a system that's failing them. And I really like to prod our clients and encourage them to think about the access to care for women and their families when they're trying to look through new solutions.
Yeah, absolutely. So now we've talked a good deal, about why thought should be given to the unique care or to the unique needs of women. But now, based on our observations through personal experience and the work that we've done for our clients, where do you see the market going? Kind of what do you anticipate or expect maybe the questions of the future to be? What questions are going to be necessary to drive those innovations to support and really present a clear understanding of the needs of women, because that may be just as important as the solutions that are being provided from our clients in the healthcare space.
Yeah, Abigail, I'd like to talk a little bit about some of the developments we're seeing, and we know that things are happening very quickly and lots is happening in the healthcare arena today. And of course, it affects all patients and all consumers. We'll circle back to the women question or the woman question, but there are three different developments that I think we should be thinking about. The first is the use of technology in general. So think about virtual healthcare. This is the idea that you could get an X-ray in your city tomorrow, but it is actually being read by a technician who's hundreds of miles away. Or the idea that when you want to see a healthcare professional, you can schedule an office visit via Zoom, something that really gained traction during COVID. None of that is going away. A second area we might contemplate developments is in the area of devices. So we're seeing a lot of increased pressure on and sensitivity about sustainability. So it may be at some point in the very near future, the idea of using a medical device just once and discarding it will no longer be a thing. A lot of attention being paid there. But also think about the ongoing digital transformation and the increase in the use of connected devices. And I'm thinking way beyond continuous glucose monitoring. This could absolutely expand massively. So these, of course, are devices that collect and store and analyze and transmit data, which could include adherence to medication, vital signs like your oxygen levels, how much you're getting up and getting around and moving. And we might actually see the application of artificial intelligence to these devices, whereby you might receive some very basic recommendations for your device as to how you might respond to those data. It's also very possible that we will see in the near future nano devices. So these are devices that you would ingest, and they would slowly release a medication on a predetermined schedule inside your body and then be excreted when they are depleted. Or maybe they would be Wi-Fi enabled so that you could provide those dosing instructions through your smartphone or your smartwatch. So all of that is very real and possible. And then, of course, the third big development that I think we're all probably watching quite closely is the advent of medications for weight loss. So I had a physician tell me, I don't know, a week and a half ago or so in an interview that there are actually around 250 diseases related to obesity and metabolic syndrome. So at a certain threshold BMI, one might be at risk for as many as 250 different diseases. So in that context, we're seeing a huge uptick in research investment, looking at molecules and peptides and proteins and combination drugs that could affect multiple disease pathways, which could also give rise to what we call personalized medicine or precision medicine, wherein a drug might be tailored to subpopulations based on their predicted response to a drug, their so-called molecular signature, or their risk profile for any one of those or subset of those interconnected diseases. So you can just see how this market will explode, and it remains to be seen how payers will respond, how many of these drugs and in what situations they'll be reimbursed versus represent an out-of-pocket cost. So again, these trends clearly affect all of us, but women may behave very differently in the context of all of this, what they decide to engage with, what they reject, how they make these decisions. One of the great points Janet made when we were preparing for this webinar is we can give people the greatest technology ever. It's the greatest thing since they put beer in six-packs. But if it represents an additional burden for the individual or the family, additional stress, how do I fit it into my daily life, additional, cognitive load about how you do that, they may reject it. It may be a complete non-starter. So as Colleen said, in the context of women as the chief medical officer of their family, they are pivotal in deciding which of those myriad developments is going to be relevant or important for their family. And I would go a step further and say that women are often the chief executive officer as well. Just one data point supporting that idea, it is said that anywhere between 70 and 80% of single parent households are headed by women. So that executive function is elevated even further. So it's really important to understand how women specifically are going to respond to all this great stuff we're throwing at the market.
Yeah, Stephanie, thanks for the call out. I think I could summarize really quickly what you said by saying we don't want to have technologies that are looking for problems. We want to be solving problems with technology. And so part of that is making sure that not only is whatever therapeutic aspect or physical benefit or health benefit that it's offering is optimized, but also that, like you said, it's designed at the lower level of the interfaces and how you integrate it into your daily life for usability and ease of use. And that's, really something I'm obviously passionate about, since that's what I do for my work in research. But I just think that was a great summary. Thank you.
Yeah, absolutely. And I think there's a big piece of this too, that as we're creating all of these developments and really entering this exciting period in healthcare, it's so important too to keep track of how all of these factors are interacting with each other. And especially if so much of this burden of decision making and management is placed on a woman, she's not going to be managing that potentially only for herself, but for her children, for her spouse, for those around her. And knowing and understanding that full ecosystem that they're operating within is going to be super important. So I think with that, there are a lot of great things coming to market, and I think we all have thoughts and ideas about how that might work for women, but there's a really big difference between ideating on what the future might look like and actually getting to a point where those solutions that are being developed are targeted, meaningful, and innovative and available on the market. So when we think about the role that we as market researchers and strategists play in this scenario, what's coming to mind? Really, what can we and how can we help our clients better understand the way in which their present day activities help or harm women? And why do we feel like this is so important?
Yeah, great question, Abigail. I'm happy to take this one. So it's important to focus more attention on women, especially in market research in the healthcare space, because we often see that healthcare advertising targeting women misses the mark completely. So I've experienced this disconnect between women as healthcare consumers and men as healthcare providers, both in my personal and professional life. So whether we're talking about the biased gender representation in media, so for example, having male actors depict patients with a condition that disproportionately impacts women, or the oversimplification of women's health needs and centering around reproductive health, it's common to see health and wellness products and services targeted towards women being created by men. And sometimes they have a limited and sometimes inaccurate understanding of what women want. And then furthermore, I would argue to understand what the biggest personal health issues are for women, we need to be sure to include women as patients in market research. So by encouraging women to share their experiences and perspectives in market research, we'll have the capacity to comprehend and represent diverse viewpoints, which is really crucial for developing accurate and informative market insights. This is especially true, as we've discussed as a panel collectively, that there are certain health conditions that affect women differently, present in women differently, or affect women disproportionately. So ensuring that female patients are included in market research will hopefully lead to more informed decisions in the healthcare industry. And then finally, I would add that in order to improve the US healthcare system as a whole, we not only need to include women HCPs and payers in market research, but we need to go one step beyond this to advocate for women leaders in STEM fields. So what I mean by this, I'll demonstrate some of this by some statistics. So women are vastly underrepresented in healthcare leadership positions in particular. Only around 30% of C-suite teams are comprised of women. And despite women now making up the majority of medical school students, they hold just 3% of chief medical officer positions, 6% of department chair roles, and 9% of division chief positions within the healthcare field. So achieving gender equity among leadership in healthcare is something that will definitely help to advance women's healthcare as a whole.
Yeah, and Colleen, just to build on that, first, I love that you always bring statistics to the table. It's fantastic. And I've lived those statistics firsthand, actually, often as the only woman in a lot of engineering teams that I've been on, or one of few. And as I said in my introduction, we tend to, it's an unintentional bias. People are not going out to be biased, but we just know that it's there. And we have to guard against it and develop these products really with the right lens and the right research to get to that capability. And I think even as women, we have to guard ourselves against the biases because we internalize some of those as well. And we want to be careful that we don't bring those into our research and do that as well. So ultimately, we want these systems and routines. If you have leadership, if you have representation, we're going to start, I think, seeing more equity and more balance in our product development processes.
And there's so much that goes into putting action behind words and intention, you know, like we just talked about, a lot of it is being intentional about how we're thinking about research, about the questions that we're asking the people we're talking to. So from our point of view, what's the benefit of working with Ipsos on these types of projects and helping to uncover the ways in which we can improve women's health? How do we really work with our clients to push the status quo when it comes to considering women in healthcare decisions?
I can jump in there. So I think one of the things that we're doing is we're looking to push our clients to look beyond products, devices, solutions that are created for women solely, and really look to understand how all products and solutions affect women or are influenced by women. So when we are looking at solutions designed for women or with women in mind, we're really asking our clients, was this truly designed for women, or is this something that's been adapted by women? In other words, has the solution, have women been included in the design process for a solution? And I think that's really important. We're also looking at solutions for women across their entire life cycle, not just in their reproductive years. Women are more than just their reproductive organs, so I think it's really important that we're asking, does the solution take a whole person approach to women rather than breaking them down into certain functions or conditions? So we're really looking to understand the barriers and motivators for women in adopting new products and solutions, and really looking to deep dive into the fundamentals of the decision-making process for women, and really pushing our clients to go in that direction with us.
Yeah, thanks for bringing up several great points, Ashley. So women's health, while certainly not being limited to only maternal or reproductive care, definitely encompasses a broader range of aspects. So nevertheless, though, there is value in market research focusing on women-specific conditions such as contraception, fertility, maternal health, and menopause. So if we take menopause, for example, women are spending a significant portion of their life in the peri or postmenopausal space. And it's projected that by 2030, over 1.2 billion women globally will be in these stages. And the majority of women will experience some menopausal symptoms while they're in this phase of life. Some of these symptoms include hot flashes, night sweats, and sleep disturbances. So as you can imagine, the economic burden is quite immense. The economic impact of hot flashes alone is over, one per person is over $1,000 in healthcare cost and $700 a year annually in lost productivity. So nevertheless, despite these big social and economic impacts, women-specific conditions like menopause often go under-researched and underfunded. So Ipsos recognizes that there's great social and economic value in dedicating adequate resources to some of the conditions that are women-specific or women-only conditions.
Yeah, and Colleen, to tie together some of the threads that you've been talking about throughout this, the need for that deep research into women's needs. Again, like you talked a lot about menopause, and there's so many solutions out there for people in perimenopause and menopause, but there's not good evidence on whether they actually work or you know, or anything particularly innovative. So really getting that deep dive into those would be really helpful, I think, for a lot of people across the lifespan. And, you know, I think it starts with getting the people into leadership, but it also starts with just, I think, a societal or cultural, or even, to be fair, like a regulated process that really helps us understand when and how to do this research more effectively. So if we think about women historically being excluded from clinical trials, right? Regulations now for clinical trials require that you need to balance those things out. You can't just say we're not going to have women in our clinical trials anymore. And now we have a need for more diversity, intersectionality, things like that as well in our trials. And, you know, I don't do clinical trials, but I do kind of the partner research and getting those products to clinical trials and to markets with the design. And we're fortunate on our side that we are required to consider the user's characteristics from their biology, how they do their work or how they live their lives, what their home environments are like, and really understand that and apply those as requirements into our product design. So I do think, as someone who works in the more regulated aspect of the healthcare industry, that there are some aspects of either cultural or regulated spaces that we could help adapt that in the long term.
Yeah, definitely. Go ahead. Sorry.
I was just gonna add too, like, you know, I always forget to do this. I get excited about the design, but I forget to talk about how good design and really understanding that results in a big return on investment for everyone. So when you talk about lost income opportunities because people don't have good solutions for hot flashes, right? So if we're really thinking about how to design that and what products work, you know, the return on investment is beyond just selling the product. There's a societal impact as well to that work. So I want to, you know, we've got to think big at a society level, not just down at the lower product level as well when we think about ROI.
Mm-hmm. Yeah, absolutely. And I think a lot of the commentary that's been coming out during this conversation too is really focused on kind of the immense size of the women's health market and the growing group of women that's going through menopause, that's aging into these different categories that maybe have been considered niche in the past, but niche in this case now, as we're looking at the sheer size of the workforce and the opportunity that exists for them to make an impact overall, you know, it's opportunity for the greater good for all of us, you know, to work towards a solution that helps improve outcomes, but also it's a huge market of opportunity for healthcare companies that to play in the space and be the first to market with a true understanding of women's health really could be beneficial in a big way for the bottom line. And so now, thinking beyond asking like the right questions and kind of knowing the process and regulations that underlie this desire to do research, it's really equally critical to make sure we're talking to the right people. So we know as researchers that who you pose a question to is really just as important as the question itself. So with that in mind, how do we help our clients to identify the right people to talk to, and why is it important to include these diverse perspectives?
Yeah, Abigail, I'll take that. I'm really good at getting down into the weeds, I think, as a qualitative person. But if I were a client, I think I would be taking a really hard look at my quotas, the composition of my sample. And it's very typical in qual, it seems to me, to say we want an even mix of gender binary people, or maybe we have a more specific goal in mind based on the particular product or objectives or what have you. But I think we might do well to think even more about quotas within gender groups. And I have two thoughts along those lines. One is going back to what Colleen was saying, with the aging of America, women are the primary caregivers. So we're taking care of aging parents, maybe aunts and uncles, maybe siblings, maybe disabled children. We are front and center in that role. And as such, those who are in that caregiver's care may do well if her understanding of a device, a disease, a drug, a health insurance program, or any other service for that matter, if the caregiver understood it as well as the patient, if not better. So it's reasonable in my mind to consider including caregivers in market research, who are usually women, because they may ultimately be a very relevant and influential target for education, messaging, you know, cultivating mastery of a device or mastery of interacting with the program or you know, health insurance program, whatever. It shouldn't be an afterthought. They may well be a core part of our sample. And the other thing to consider, which Abigail brought up at the very beginning here, is women in the context of social determinants of health and diversity, equity, and inclusion. So we're generally talking about people who may be less visible, less vocal, perhaps a lot less well-insured than others, but they still have a lot to teach us about the consumption of healthcare, especially when viewed through a lens that might be less familiar to many of us in the field. So I also think about SDOH and DEI from this point of view, which is women need to be healthy in order to be financially viable and independent. And there is a lot of evidence to suggest that when women are contributing to an economy, the overall welfare of the society is improved. There's a meaningful impact. So we kind of owe it to ourselves to make sure women are participating and having a voice. It's the concept of a rising tide lifts all boats. So if we think about including representatives of these subpopulations, or maybe they're not even subpopulations, you know, important populations in our research, it brings us closer to what I feel is part of our mission as market research professionals working in healthcare. To get on a soapbox here for just a minute, I mean, I'm not a healthcare professional, but by playing in this space, I feel like I'm playing my part to improve people's lives. So it's about making sure that women have an opportunity to participate and be heard and be more visible, which kind of, it's the rising tide that lifts all boats.
Yeah.
Stephanie, I think
Yeah,
that
absolutely.
I think as we start to look at including women more often in our research and be more intentional about including women, we're also going to see that the way we ask questions and the type of research that we do is also going to evolve. So we're making sure that we're asking questions and designing research around, for example, drivers and barriers, and including attributes that are specific to women in those questions. And I really see us moving towards approaches that focus on communication, relating to patients in a more personal way, focusing on that connection between patients and providers. And I think as we start to bring in more women to our research, I think we're going to see that impact the type of questions that we ask and how we approach research overall.
Yeah.
Definitely. I think these are all really great points and things that our clients can sometimes forget. Like, you have to really keep that end user in mind throughout the entirety of development. It's not just a box you check at the beginning or at the end, you know, when things are kind of signed, sealed, and ready to go, and you're just trying to confirm that, like, oh, well, is this appropriate for all of our groups? Can they use it? You know, maybe not the right question, you know, to ask, or the right time to ask the question, I guess. And I know, Janet, you had said during one of our sessions that R&D really needs to be just as driven by the R as the D. And I thought that that was just a really insightful comment, because we do see kind of this tendency, I sense, to view women's health, or really anything that diverges from what we call, you know, quote unquote mainstream problem, to be perceived as niche. And a niche, you know, product is, especially in women's health, really not niche. It's something that's common, or a problem that's appropriate for a large group of the population. And so personally, I'd really love to see our clients come to the table committed to a whole program of understanding, with that explicit dedication and attention to the role and need of women as patients, caregivers, and providers of care. You know, and today, I think especially, we've talked a lot about women as patients and caregivers, but they're also the users of, you know, major medical devices. They're the prescribers of drugs and all of those things. And I think it's really important to keep a specific eye too on women and the factors that may be influencing their ability or willingness to use products that are designed for them as practitioners. You know, and all of that to say that a research program that's designed around women, or explicitly focusing on how does this apply to women, doesn't result in a product that's equally as usable for a broader population. But I think it's really important to just remember that without expressly dedicating those resources to understanding the unmet needs and the unique journeys of women, it's very impossible, it's near impossible to create a solution that goes beyond that one size fits all. So with that in mind, what are some of the related Ipsos capabilities that we can harness with our clients to meet these goals? What can we and how can we help our clients to find the audiences to put the spotlight on?
Yeah, definitely. Great question, Abigail. So I wanted to bring up one option that Ipsos has that's really great to use. It's called Knowledge Panel. It's a panel of nationally representative sample of US adults. It's achieved by households being selected at random via address-based probability sampling, which allows for the accurate representation of US adults. It also includes non-internet households and a Spanish-speaking dominant population. So it's good to use when you need to represent certain populations, such as older individuals or low-income individuals. So you would use Knowledge Panel when the research is high stakes. So it's a good option for research that has elevated scrutiny or impacts high-risk decisions, such as public releases or government filings. You would also use it when size matters. And what I mean by that is the ultra-precise population sizing estimates allow for conducting a market sizing. So you get the true size of the market that you're after. It's also a great option to include when you're targeting a specific population. So it allows us to give voices to audiences that are typically or historically have been underdeveloped in online panels. So older individuals, racially ethnic minorities, or lower income individuals. So if you're looking for a solution that has a nationally representative sample or looking for market sizing, Knowledge Panel is a great option that Ipsos can provide.
Yeah, and from my perspective as someone who works across the R&D cycle, so we work early in the research process to understand unmet needs, people's capabilities, their limitations, things like that in order to design a product appropriately to fit into the world and be used. I think one of the most powerful things about that early research is that it can be used to predict the future needs of healthcare, right? So when I hear us talk about women have often been treated as niche in development cycles, or we want to advance towards places where durable medical equipment is more sustainable, for example, longer lasting or has more uses. If we tie those two things together, a good example of what's going on currently is that historically men have made up most of the surgeons in the operating room, but women are becoming an increasingly large number of female surgeons. And when we tie that with recent research that's just come out that women, have sometimes a lot better outcomes, despite some of the limitations they experience in the operating room. Imagine what they could do if that medical equipment was designed to be adaptable to a broader spectrum of people. And, I think when we start to include women more broadly at that point, thinking about just people more broadly, about who could be in that operating room, what are they doing, how can they do that? And I think it really can lead to new innovative solutions in that point. So instead of having our female surgeons have difficult repetitive strain injury or pain or fatigue more often and compared to their male colleagues, now we're making it better for everybody by applying that broader lens of need and use into those areas. So big fan of the R and love when it leads into the D.
Janet, you mentioned two specific examples when we were preparing, and these were not obvious to me, so I'm just going to mention them. Maybe they're not obvious to others. The idea that women practitioners might have different hand strength to interact with the device, or they're a different stature, their arms are not as long, or whatever, their forearm strength is different. So it's really basic stuff like that. And you also made the point earlier, on the one hand, we want to be different, but we don't want to be too different, but those are differences that need to be contemplated, especially if most of the medical students today are female.
Yeah, and it's interesting because that data, there's a lot of data, anthropometric data around, and it's been around for decades, including it started in the military, right? We know the forces that women apply differently to devices for grip strength and things like that. And I've had to pull those up a lot in my job. And often what happens though is the requirement you get just sort of covers it, because we're trying to build one device that works for everybody instead of a device that's adaptable for everybody. So we want our products to adapt to our users, not make the user adapt to them. That's what we talk about a lot in our field. And so we can have all that information at our fingertips and still struggle in those development processes. So it would be great to kind of take that lens out and make the product adaptable, not the person adaptable. So.
I think also speaking of adaptability, if we think about the actual kind of bread and butter research that we're doing at Ipsos already, there's a lot we can do to better serve women. So when we think about our qualitative interviews, be they longer term communities, ethnography, or even social intelligence, we can think about the way that we're pulling in the lived experience of women, either as patients or HCPs throughout the disease journey, like we were talking about earlier, making sure that we're kind of thinking about the disease journey from a woman's point of view, and it not just kind of looking at it as a norm where most of the time we're kind of considering men here, pulling out exactly where it's different for women and what the opportunity areas there are and how we can better help them. It's also true in quant as well, like Stephanie was saying earlier, if we're clever with the way that we make quotas and filters, we can better adapt our ATUs, but also thinking about like the segmentations that we do, not just making sure that we've got women that fit into them, but actually how is this segment different when you consider the female perspective and when you consider the male perspective, and what are the characteristics there, and what should we be thinking about with the marketing, like Colleen was talking about earlier, kind of tying the loop for everything. You know, a segment is a segment, but there are like minutiae in between them, and making sure that we're not just having it as one homogenous group and thinking about the diversity that's there. And I guess the other thing is, you know, we're obviously very passionate, and I know that a lot of our colleagues on the line who our colleagues not on the line are equally as passionate. And I think that's kind of the best thing I found working here, is that it's something that people want to talk about and we want to kind of bring forward to our clients as much as possible.
And we can help them make it easy. It doesn't have to be this really overly complicated, over-engineered process. You know, I think just a little bit of thought and attention, even within a pretty standard research program, could go a long way in terms of furthering the perception of women and women's healthcare needs. So we're pretty much up on time here, but I think we have time for just one question from the audience. So I think, Ashley, this one sounds like it is right for you. So thinking more specifically about health insurers and how they play a role in the healthcare system, you know, what role do or should they play in women's health? Kind of how do you see the environment for health insurers changing as we put more of a focus in emphasis on access of care for women?
Yeah, so I think that's interesting because health insurers have a really unique place in the healthcare ecosystem because they see everything, right? They've got all the claims data, they know all the interactions that happen. So they've got this big picture women of how people, and women in particular, are interacting with the healthcare system. Where I think they have some room to grow is in understanding the journeys that women have to take, both within the expected pathway and then all the workarounds and other things that they have to do in order to get the care they need for themselves and their families. Because there's the way it's supposed to work, right? And then there's the way it actually works. And I think health insurers have a great opportunity to take that big picture view, to take all this data and information they have, to take all these interaction points that they have and opportunities along the care journey, to really focus on how can they make it work right and how can they increase access at each stage in a way that's going to ensure that not just women, but their families and those they care for are getting the care that they need. I think if they focus on women and how women interact, that's going to percolate out to the larger healthcare system and everyone who needs care.
I think that's such a good point. Like, the health insurer really is kind of the central player in all of the aspects of women's healthcare. And so being able to look at it from that broader perspective and understanding you can't get care you can't receive the appropriate devices and prescriptions and everything if you aren't able to access it through your payer. And so being able to address that, I think, is going to be really important. So interesting all the way around to think about that. Even these systems that feel somewhat more agnostic maybe of gender impact can still have really big impact or ways to improve when you think about the role of women and gender specifically. All right, well, thank you everyone for joining us. We are pretty much out of time now. So a special thank you to all of our panelists who have participated today. And like Katie said, and as you've probably noticed through this conversation today, we have a whole host of people within Ipsos who are passionate about women's health and helping our clients find clarity in this multifaceted space. So if you'd like to continue the conversation with any of our panelists or just learn more about our capabilities overall, please feel free to reach out to any of us who participated in this webinar today. We're more than happy to talk with you extensively or not so extensively about healthcare research and how women can or should be factored into your research processes. So yeah.
Thanks, Abigail.
Okay, great.
Thanks,
well,
everyone.
thank you everyone again.
Bye-bye for now.